Today's presentation is by Dr. Lomo, one of our fellows. For those of you who are at the Vision meeting, you know that we spoke about some new programs that that CVR is going to be instituting. We have the stocking program, we have the new VitaDocs. We also talked about expanding our wound care program. So Dr. Lomo is going to talk about a patient that I think even Dr. Malhotra may have taken care of this patient. It's a very complicated venous ulcer wound care management issue, but it kind of touches upon all the things that we talked about in the wound care talk at Vision. So Dorcas, go ahead, you're up.
All right, perfect. Hi, everybody. I'm Dr. Lomo. I'm one of the fellows here in New Jersey. So this is one of Dr. Papa's patients. He's been treating her venous stasis ulcer for about a year and a half. So her history consists of, she is a 66-year-old white female with multiple medical problems who was originally seen in our office on September 30th, 2021. She presented complaining of 2 right calf non-healing ulcers since March 2020, associated with swelling and hyperpigmentation. She was seen at a wound care center where she was treated with Unabud and had 2 failed split thickness skin grafts in May and July of 2021. She now presented for a second opinion and further treatment. Past medical history: depression, anxiety, hypertension, hypercholesterolemia, obesity, breast and skin cancer. Past surgical history: split thickness skin graft, lumpectomy. Her medications were Effexor, losartan, meloxicam, Crestor, Docusat, Myrbetriq, and anastrozole. She had no known drug allergy. She denied smoking, alcohol use, or drug use, and she worked as a director of a blood bank. On physical exam, she had palpable pedal pulses bilaterally, and she also had a 6 by 6 centimeter and a 3 by 3 circular full thickness wound present on the right medial anterior mid calf to distal calf. The wound was surrounded by erythematous tissue and had moderate slough. Maceration was noted around the wound edge. There was also hyperpigmentation of the right lower leg. Wound healing is a very complex and dynamic process that occurs after injury to the skin sites. There are different types of wounds: surgical incision, traumatic wounds, leg ulcers, and tissue gangrene. We also have 4 phases of wound healing. We have hemostasis, inflammation, proliferation, and maturation. With hemostasis, this is the first stage of wound healing, and it occurs immediately after injury. It is characterized by the activation of the clotting cascade, which results in the formation of blood clots. This clot helps to stop the bleeding and provide a scaffold for cells to migrate to the wound site. The next phase is the inflammation phase. It begins within hours of injury and lasts for several days. During this phase, the blood vessels in the area dilate, they become a little bit more permeable and allow the immune cells and other factors to enter the wound site. This results in the redness, the swelling, the heat noted. The immune cells then remove debris and dead cells and also secrete cytokines and growth factors that are needed for the next phase of wound healing. And then the third phase is proliferation. So this phase begins several days after injury and can last for several weeks. There are new blood vessels that form, and cells such as fibroblasts and keratinocytes begin to migrate into the wound. These cells, they secrete extracellular matrix such as collagen, which helps to build new tissue. The wound also begins to contract, which helps to reduce its size. And then the fourth phase, we have maturation. This begins several weeks after injury and lasts for several months. The wounds continue to mature and the tissue become a bit stronger and more functional. The extracellular matrix is remodeled and the tissue becomes less fragile. The final result is a scar that is less noticeable and more functional than the original wound. We also have several factors that can cause wounds to fail to heal. We have bacterial overload, lack of granulation tissue formation, absence of moisture, insufficient blood flow, excess edema and exudate, and tension on the wound. So our patient failed 2 procedures with the split thickness skin graft. What is this particular procedure? So it's a surgical procedure in which a thin layer of the skin is removed from a healthy donor site. It could be the abdomen, it could be the upper arm, the thigh, and then it's transplanted to a defect or the wound site. And this graft is then placed through a machine that creates this mesh and fenestrated like pattern on the skin. And then the skin is eventually placed on the recipient site and secured with sutures and staples. It is important to continue with monitoring and management of the graft to ensure that the graft takes properly and continues to not get infected. This may involve regular dressing changes, antibiotics, and protection from trauma or pressure. This article was a retrospective study at Copenhagen Wound Healing Center in Denmark. What they found was that Pseudomonas in chronic venous leg ulcers, despite treatment, had considerable impact on partial take or rejection of split thickness skin graft, which emphasizes on the importance of debridement to remove non-viable tissues and biofilm. So our initial treatment plan was to start off with betadine wet to dry. The use of betadine was to eradicate any type of microorganism on the wound surface, which then reduces the risk of secondary infection and promotes faster healing. Other than betadine being an antiseptic, it also can help to remove the dead tissues and debris and provide mild pain relief. As you can see, the wet to dry method removed a significant amount of the biofilm noted in the initial picture from September 30th, 2021. The problem with the biofilm is that it is surrounded by a extracellular matrix. And this extracellular matrix is a protective barrier against the environment and helps to protect the microorganism from any type of antimicrobial agents such as antibiotics. Therefore, during week 4 of treatment, the patient was started on Levaquin for 4 weeks. Then she was started on Uneboot weekly. In her initial duplex scan on September 30th, 2021, we can appreciate that there is significant reflux from junction all the way to distal calf, except for the above knee site. And this was the site where her venous stasis ulcer was located. We treated her wound for about 1 month, and then we proceeded to treat the GSV. So for the treatment plan, the right and the left GSV, we did RF. And then for the right distal calf of the GSV, we did the USG. And then the left was a phlebectomy. And then we went back to the right and did another USG on the right tributaries. During her 1 month post-ablation follow-up, this was around January 2022. Her scan showed appropriate occlusion at the treatment locations, and the patient also indicated that her symptoms had improved, but of course her ulcer persisted. So this was her wound appearance after completion of the venous interventions. There was no change in the size of her wound when compared to the initial consult. Therefore, our next step was to initiate Apligraf application. The patient received 4 applications of Apligraf, which is a type of wound care biologic. What wound care biologics are: bioengineered skin, which is derived from living organisms or cells. There are 2 types of bioengineered skin substitutes. We have the Apligraf and the Dermagraft. Skin substitute are tissue engineered product designed to replace either temporarily or permanently the form and function of the skin. Skin substitute are often used on chronic non-healing ulcers, such as pressure ulcers, diabetic neuropathic ulcers, and vascular insufficiency ulcers. So how do we compare the Apligraf to human skin? Apligraf was FDA approved in 1998 to heal venous leg ulcers and diabetic ulcers. Apligraf has a bilayer. It has active components of living skin that consist of a layer of keratinocyte and fibroblast, which are the principal cells of the epidermal and dermal layer of the skin. The upper layer consists of the human keratinocytes, which closes the wound and produces growth factors and cytokines. And then the lower layer consists of the dermal fibroblast. It is also comprised of a bovine type 1 collagen combined with the human fibroblast. This fibroblast is extracted from postnatal foreskin. As you can see in the image, the allograft and the human skin are particularly identical. The allograft looks, functions, and responds just like human healthy skin. In regards to growth factors produced by allograft, the human skin cells in the allograft secrete growth factors and other cytokine or signaling molecules that stimulate the migration of cells to the wound site and promote the formation of new blood vessels, new human collagen, and other matrix components. As you can see, the allograft secretes the same type of growth factors as human skin. This helps to create a more favorable environment for healing and reduces the risk of infection. This clinical trial showed that there were 47% of patients treated with allograft achieved complete wound closure in patients with hard to heal ulcers. In the study, the allograft was used every 6 weeks rather than every week. And allograft specifically is recommended for venous ulcers and diabetic foot ulcers. The other bioengineered skin substitute is dermagraft. It is a sterile, cryopreserved human fibroblast, which is a dermal substitute generated by the culture of neonatal dermal fibroblasts onto a bioabsorbable polyglactin mesh scaffold. The fibroblasts multiply and secrete growth factors in matrix protein, and then the end product contains well-developed extracellular matrix with living fibroblasts. This particular skin substitute is used best with diabetic foot ulcers. And then these are other skin substitutes to also consider. Purify. It is a purified native collagen matrix with broad spectrum antimicrobial agent. It has the polyhexyl methylene biguanide. And then we also have placental allograft, Affinity, and NuShield. Affinity is a fresh amniotic membrane containing many types of viable cells, growth factors, cytokines, and extracellular proteins for treatment of chronic and acute wounds. And then the NuShield is a dehydrated placental allograft wound covering that retains all the layers of the placental membrane. Purify is effective barrier to control bioburden, and it also prevents biofilm reformation, especially in chronic wounds. The product has been launched for management of multiple wound types, including partial and full thickness wounds, pressure ulcers, venous ulcer, diabetic ulcers. And then Affinity, in combination with the standard wound care, has demonstrated to improve wound healing as compared to only the standard care of treatment. And then NuShield, it may also be applied on partial and full thickness wound. Apparently, it helps when there's an exposure to tendon, muscle, joint capsules, and bones. So on January 18, 2022, we initiated the allograft on our patient. As the weeks progressed, we can appreciate a little bit more granulation tissue and less slough. As you can see, in the last week of allograft use, her smaller wound had almost healed completely, and there was a lot more pronounced granulation tissue. The patient wound healed 3 months after allograft treatment. There was appropriate skin growth noted, especially on May 24th, 2022. At this particular visit on May 24, 2022, the patient was advised to follow up as needed. However, 1 week after discontinuation of the Unaboot, the ulcer started to reoccur. Therefore, we proceeded with next steps. We increased compression from 20 to 30 to 30 to 40. We ordered a pelvic venous ultrasound, and then we just continued the UNABOOT weekly. Each week, her wound size increased. In the second picture, her wound measured 4 by 2 centimeters. In July, venogram showed 68% stenosis of the left common iliac vein extended into the IVC. Dr. Pappas proceeded with a stent placement. Also, during this period, there was a discussion about repeating the appligraph if the wound remained open. In August, we repeated the appligraph application. So here are a few pictures of each week after the appligraph application from August all the way to ending of September. She had received at least 4 applications. And to reiterate, this was about 3 months post the previous appligraph application. Over time, we noted new skin growth, and each week post the appligraph. On October 25th, 2022, patient was advised to follow up as needed because, as you can see, the wound had completely healed. 2 weeks later, she presented with recurrence of the wound. Therefore, we went ahead and restarted the UNABOOT. We then referred the patient to orthopedics for MRI to assess for soft tissue damage or to also rule out osteomyelitis. We advised her to continue the 30 to 40 compression stocking. So when patient went to ortho, they referred her to infectious disease. Infectious disease then ordered an X-ray of the right tibia and fibula, which noted no acute osseous abnormality. Infectious disease then indicated that there was a low likelihood of osteomyelitis and that the X-ray should have shown some type of changes if osteomyelitis was present. And then infectious disease indicated that MRI could be considered if the wound worsened or if there was concern for osteomyelitis. At this point in time, we just continued the UNABOOT, and from November until this week particular, as the weeks progressed, the wound improved. Last week, for example, February 7th, this was her wound. And then February 14th of this week, it had completely healed. At this point, we recommended for the patient to follow up as needed. Chronic venous insufficiency in legs is a disease as a result of venous circulation disturbance. Venous leg ulcers is the most advanced chronic venous insufficiency. Risk factors include advanced age, obesity, female gender, DVT, and phlebitis. Standard of care includes local wound management and compression therapy. The average time for the venous leg ulcer to heal is about 6 to 12 months. And then we should also consider advanced treatment therapy if standard treatment fails. It is also important to educate the patient on self-care, mainly how to take care of the wound. Physical exercise and diet should also be important informed to the patient, because these are important parts of treatments that lead to therapeutic success. We should also consider some adjuvant pharmacological therapies. For example, some of them are shown to improve blood circulation and local wound environment, such as pentoxifylline, which is effective when combined with other standard wound treatments. There was a meta-analysis that showed that pentoxifylline was significantly more effective for complete or partial ulcer healing than placebo or no treatment at all. And then there is also Essen. It's another pharmacological agent that may be used in patients unable or unwilling to use compression, or for those in whom compression is contraindicated. There are 4 aspects of wound bed preparation that should be systematically considered in order to allow the wound to heal. First is tissue. We should consider wound debridement if there is significant exudates, necrotic tissue slough biofilm, or even foreign body. And then next is inflammation or infection. Ideally, consider topical antimicrobials or systemic antibiotics in case of infection. And then moisture imbalance. use dressings that add a little bit more moisture, such as hydrogel or hydrocolloid. And then epithelial edge migration or advancement. This helps to facilitate re-epithelialization, meaning that the debridement of the edge of the wound or use of skin grafts or skin substitute helps the epithelial cells to migrate across the wound. And then here are some innovative therapies for chronic venous ulcers. Negative pressure wound therapy uses a vacuum-assisted dressing to promote wound healing. The vacuum helps to remove excess fluid and debris from the wound while also promoting growth of the new tissue. And then there is also hyperbaric oxygen therapy. It involves exposing the wound to high concentration of oxygen in a pressurized chamber. This therapy supposedly can help to promote wound healing by increasing the delivery of oxygen to the wound site, which is essential for the growth of new tissues. We also have topical growth factors, such as epidermal growth factors. It may be used to promote wound healing. These growth factors, they're supposed to stimulate growth of the wound at the cell site and formation of new blood vessels. And then we also have the platelet-rich plasma therapy. It involves using a patient's own blood, which is processed to concentrate the platelets and applying it to the wound site. Apparently, that's supposed to help release growth factors that can help promote growth of new tissue and new blood vessel formation. And then we also have wound electrical stimulation. It uses low voltage electrical current to promote healing in the chronic wound. And then the ultrasound therapy is a method that uses high frequency sound wave to promote healing in chronic wound. To be honest with you, a lot of these innovative therapies are investigational and experimental because their effectiveness for wound healing and reduction has not been established. Out of all the innovative therapies listed, it seems as if the biologics have a lot more clinical trials and data to solidify wound healing. And then, so with our patient, my concern is that the patient might return with recurrence of the wound. My question is, has anybody had a similar experience or if they have any recommendations? So that's pretty much it for my presentation. Thank you.
So thank you, Dorcas. That was a very comprehensive kind of review of complicated venous wound care. We literally threw the book at this lady, and I was very, very surprised when she recurred as often as she did. And I kind of still can't figure out why she tends to recur. So, and it's only in the right leg for some reason. The left leg was also swollen, but she only seems to get this in the right leg. So anybody have any questions?
This is Zoe. I'm sorry if I missed, but did you biopsy the wound edge?
We did not biopsy it, no.
Just curious.
Because it was not heaped up, it wasn't angry looking, and it kept healing. Usually when this is a squamous cell cancer or Marjolins ulcer cancer, they don't close at all, and she closed twice.
Okay.
So, but I thought that she probably had an osteomyelitis, which is why I then sent her to ID, but they said she didn't have it. So I cannot figure out why she continues to recur, especially in the same spot, but yet she responds so well to the therapy. So, I told her, I said, listen, I've used every tool in my toolbox right now. If you recur again, I don't know what else to do for you.
No lupus or anything else in her?
No, she doesn't know.
And I was going to say, I've seen pyoderma do something like this too.
Have you guys,
Yeah,
have you adjusted any nutritional, like added different protein collagens to her diet?
I didn't think of that actually. So
Something easy to do, cheap.
yeah. I mean, I guess the only other thing I would add to this, if she recurs again, is maybe put her on some diosmin or some micronized flavonoids.
Yeah.
But other than that, I'm not sure what else to do. So,
Peter, this is Shakib. The leg seems to have lost the swelling that she had primarily. Did she lose weight or
no, she hasn't lost weight. No.
Thank you.
And she also recently retired, but the job that she had as a director at the blood bank, she stood on her legs most of the time. So now I'm hoping that she won't stand as much, that maybe this will help a little bit. But the swelling in the right leg is significantly reduced. She still, believe it or not, still has some swelling in the left leg, but that's not the one that bothers her. It's the right one that bothers her.
Does she sleep in a reclining chair or does she sleep in a horizontal bed?
Yeah, I asked her that. She said no, she doesn't have any trouble sleeping. You know, maybe it's time I just send her to a rheumatologist, and maybe she has some underlying rheumatologic disorder she doesn't know about or that hasn't been looked at. That's about the only thing I haven't done on her, is a rheumatology evaluation. All right, so stay tuned. I'll keep you all
Dr. Cox, I have
informed.
a question quickly. Sorry, Mohammed here.
Yeah.
Would you consider stenting the patient if she's over 85 or at 85 years old or above?
Yeah, so
Would
I
you
don't
say-
look at the patient's age. I look at their physiologic status.
Mhm.
So, I mean, if they're a good 85 and they're up and they're walking, I'll give you an example. My mom's 89. She lives by herself. She takes care of herself. She's ambulatory. If she had a problem, I'd stent her because she's a good 89. I just have a patient who I just saw yesterday. Dr. Lomo and I saw, she's 90 years old. She's ambulatory. She, takes care of herself, and she's got a wound that looks just like this lady's wound did. And we were starting all over with her as well. So I would consider stenting her because she's a good 90.
Good. Thank you.
Where are we? Do we ever use wound vacs on the legs? And we've had so much success in other parts of the body with those things.
Yeah, I have to tell you, I've had very bad results with wound vacs for venous ulcers. They don't work as well as they do on the arterial, or the traumatic wounds. We used to use them in the trauma patients all the time with very good success. So, but for some reason, the wound vacs don't seem to do very well for the venous ulcers. At least that's anecdotal. There's no studies I can point to, but I can tell you I've not had good experience with wound vacs for venous ulcers. All right. So thank you very much, everyone. Everybody have a great weekend, and we will keep you informed, as I'm sure she will return.